So finally, we will welcome Dr. Hart. He is the lead clinician for the Public Fertility Service of Western Australia. He's also the Medical Director of Fertility Specialists of Western Australia and Professor of Reproductive Medicine at the University of Western Australia. Dr. Hart will be discussing the latest data behind ERA and bringing us a few interesting case studies in his clinic. So welcome, Dr. Hart.
Thank you very much. Well, firstly, Viviane, thanks very much for inviting me to give this presentation. Thanks very much to Igenomix and for the service that you offer our patients. And so, my remit was to give a bit of an insight, perhaps at the clinical level. We've heard some fantastic science, and I'm very grateful to the previous speakers for their overview. So, my remit was really, when should we be assessing the endometrium? And there's a beautiful picture just there of a fantastic picture of a uterus and a beautiful endometrium. But that is really what we've been doing, doing with assessing our endometrium for the last 30 years, and we really haven't got much further than that. So surely there's time to move on. So before I start, I'd just like to give you my disclosures. These are my disclosures, and none of them relate to my presentation today. So I want to just go over cause of implantation very briefly. Obviously, Dr. Nguyen has done a fantastic talk just previously. Talk a bit about the endometrial receptivity assay briefly. We've had some fantastic talks, particularly by Dr. Chang, about that earlier on this afternoon. What does the literature say? We've heard a bit about that already. And just to talk about some of my interesting patients that I've had, and similar to Dr. Nguyen's previous patient, we just heard just then, giving a fantastic success, which is obviously very personally rewarding for the doctors, and obviously an absolute delight for the patient. So along with Dr. Nguyen was saying, is about the causes of implantation failure. We mustn't lose perspective of this before wading in and talking about endometrial receptivity assay. So up to about 10% of women are believed to experience recurrent implantation failure during their journey through the IVF treatment process. And that's generally described as being unsuccessful with this ongoing pregnancy after the transfer of 3 blastocysts, good quality blastocysts. And the commonest cause, as Dr. Nguyen said, is the embryo. The commonest cause really is aneuploidy. Understandably, therefore, it's commoner in older women. But it's imperative, as he alluded to, there are systemic causes which must be excluded before we proceed on our journey of transferring embryos. Pelvic pathology, submucosal fibroids particularly, severe endometriosis, hydrosalpingia diagnosed and visible on ultrasound, and they must be removed before an embryo is transferred. A significant uterine septum, perhaps not an arcuate uterus, but a uterine septum must be treated before an embryo is replaced. And the really thorny issue of thin endometrium or endometrial adhesions. So endometrial pathology, including submucosal fibroids, are challenging, but at least submucosal fibroids can be resected, but a thin endometrium is challenging. Systemic disorders will lead to reduced chance of an embryo sticking, such as hyperinsulinemia, thyroid derangement, procoagulant situations, so hemophilia, so a thrombophilia screen needs to be performed. Parental chromosome rearrangements must be screened for. Potentially abnormal immune responsiveness, but I won't discuss this any further. It's a very thorny issue. And as the previous speaker alluded to, potentially vitamin D levels being low. So it's really imperative to exclude other causes of failed implantation. So there's no point of focusing on endometrial receptivity if there's evidence of other things going on around. So Nick Macklon in the UK has got some clinics in London and Copenhagen, and he has got a particular interest in reproductive failure, and his protocol is an RBM online, and I encourage you to look at that. And he's demonstrated that, the previous question to Dr. Nguyen was, what are the 3 commonest causes? And Nick Macklon would probably say there's no one cause that's likely to be responsible. There's often several causes, that reduce implantation, but there's no one particular predominance. So he looked at 86 women with recurrent implantation failure, defined as the transfer of 3 high-quality embryos resulting in no pregnancy, not completing pre-implantation genetic testing by aneuploidy screening, but these women were under 40 years of age and were non-smoking, and looked at those patients compared to a cohort of patients who didn't have reproductive failure. And really what he found is, as previous speakers have alluded to, a high incidence, and there's similar incidences was being reported by previous speakers, of endometritis in the RIF group of about 24%, compared to 6% in the non-reproductive failure group. Lower luteal progesterone is also has been mentioned this afternoon, and interestingly, lower vitamin D levels, which is not something I usually screen for, but perhaps I may do. So no one cause is likely responsible, but it's important to be vigilant for other causes and just do not focus on one test. And as previous speakers this afternoon have alluded to, the situation changes. The situation may change after pregnancy. The situation may change due to oscillations in body mass index. And the ERA assay may only be relevant for 2 to 3 years, but even that 2 to 3 years is pretty impressive. So what is the ERA assay? Again, there's been a lot discussed this afternoon, so I'll just whip through this. It's proteomic analysis, objectively measuring the transcriptome of 248 genes which are expressed within the endometrium by next generation sequencing, which are upregulated by a factor of about 3 times around the time of implantation, to give us an idea of the receptivity status of this endometrium, aiming to detect the window of implantation, which is quite broad, has been discussed today, anywhere between LH plus 6 to 9 in an LH surge cycle, or an HRT scale of 4 to 7 is the massive range. But as we've talked about earlier on, it is potentially narrower in subset of patients. What is fascinating, it's replicable across cycles. It's more consistent than noise criteria of histopathological assessment of the endometrium. And as we've heard about, it's often combined with assessment for endometritis and the microbiome. But this afternoon, I'm just going to really, in my talk, just talk about the ERA assay. So what does the data say? I'm going to focus a little bit about the clinical application later on, but this is the data, what is out there. And we've had snapshots of that this afternoon. But the first real study was a retrospective study by TAN in 2018. So it's all recent data, really, looking back at 88 patients, mainly had recurrent implantation failure. Some had pre-implantation genetic testing of their embryos for aneuploidy. In fact, though, the 10% hadn't had a previous transfer. So it was a bit of a mixed bag of patients, but quite a few were recurrent implantation failure. HRT cycles, as we've heard about this afternoon, HRT cycles are more easy to replicate and therefore give more consistent readings. So we'd encourage clinicians to use an HRT cycle if counterbalancing the ERA assay. Biopsies were after 6 days of progesterone. You've been hearing on this afternoon, usually after 5, but clinics vary. The window of implantation was displaced in 22.5%, with the majority being pre-receptive after 6 days of progesterone. This was limited by the study side, but I'm not going to go into the details because it was a very the first report, and there's not great statistics in this paper. But it appeared that there was some benefit to be derived from a personalized embryo transfer protocol in recurrent implantation failure patients, with overall about a 54% ongoing pregnancy rate. Basil et al. In 2018 from Bob Casper's group in Canada did a retrospective review. But what they did, they looked at 53 good prognosis patients under 42 years of age, a third of whom had PGTA, and compared them to 508 control patients. So it's 53 patients who had the ERA assay, but they were good prognosis patients. All forms of cycle, biopsies after 6 days of progesterone or 7th day post LH surge. And they found the window implantation was displaced in 64% of their 53 patients. Ongoing pregnancy rates were interestingly pretty much similar, whether they were receptive or whether they adjusted according to the ERA assay. So similar, 39 to 35%. Again, very low numbers. Cozzolino et al. In 2020, much bigger study, 2,000 patients, recurrent implantation failure, but look under 45 years of age, and you've got to imagine a substantial number of those are going to be in their 40s, where the main cause is aneuploidy. 160 patients of those underwent the ERA, 183 of those patients had PGTA, but only 21 patients had both. Analysis by logistic regression demonstrated that only PGTA appeared to improve ongoing pregnancy rate over the standard treatment by a factor of about 20%, with an odds ratio of 1.22. However, as you can imagine, in that cohort of patients, one would imagine that the main cause is going to be aneuploidy. Only 21 patients had both the ERA and aneuploidy screening, so it's perhaps no great surprise that PGTA was found to be more useful. Again, low numbers, but this is all early work, really. So the study that's been mentioned a lot this afternoon, so I'll go over it quite quickly, is Carlos Simon's randomized controlled trial in 2020. But 2020, I know it's more recent, but it took 5 years of recruitment. Only 4% of patients underwent PGTA, started way back. So I'm breaking this down for ease of reading. So this was presented at the ASRM last year and published this year in RBM Online. Does clinical performance of a personalized embryo transfer, so according to the ERA assay, guided by the endometrial receptivity assay, the ERA, differ from a frozen embryo transfer or a fresh embryo transfer in infertile patients? As I've said, this has been mentioned quite a bit this afternoon, so I'm going to go through the results quite quickly. But this is the only randomized controlled trial. And the problem with, unfortunately, was they expected a 30% dropout in this study. However, the dropout rate was 50%, which was substantially greater than they anticipated. Consequently, that seriously undermined the power of this study to get any statistical significance. So consequently, the data that's been presented this afternoon, and I'll briefly mention now, is really muddied by the fact that there was a much greater dropout than would be expected. So this was a multi-center study. It was performed in 16 sites, open label, randomized controlled trial. Because obviously the patients realized they were having an endometrial sampling, so it's obviously open label. 458 patients. They were young patients, under 37 years, but this is the first appointment. This is not your recurrent implantation failure patients. It's the first appointment, and they were randomized to this personalized approach, or perhaps your standard IVF and a frozen transfer after a freeze-all or a fresh embryo transfer. So you can see there's two problems here with this study. I mean, I've got to admire Professor Simon for doing the study, and absolutely and hats off to him for doing that. But there was substantial dropout in this study, and it's patients who are having their first up go by having this biopsy. So it must be said, and it's been mentioned briefly this afternoon, but it's an expensive test, and it's also an invasive test. I mean, our patients who have had recurrent implantation failure, as you all know, clinicians, they've gone through a massive journey, and they're prepared to put themselves through anything to achieve their desire of a baby. But it's for a woman in her first starting her fertility journey to have an endometrial biopsy. It's a big procedure to undertake. So that has to be stated, that it's a big thing to embark on, and understandably, many patients did drop out. And also, one would imagine that perhaps this isn't perhaps the right cohort to do the study on. So what were the results? Well, we've heard about it this afternoon. If you were analysed by intention to treat analysis, and results were comparable. Remember, massive dropout, but the cumulative pregnancy rate was significantly higher in the personalised group. So this was all treatment up to 12 months after the biopsy. It was 94% pregnancy rate in the personalised approach, compared to frozen cycle of 80%, and the fresh transfer group also 80%. But if you analyze per protocol, that live birth rates in the first embryo transfer were 56% versus 42 in the frozen and 45 in the fresh embryo transfer. I'll now skirt over this because obviously it's been mentioned a lot this afternoon. So in conclusion, despite 50% of patients dropping out compared to the 30 planned, the per protocol analysis demonstrated significant improvement in the pregnancy, implantation and cumulative live births using a personalized approach compared to the standard frozen embryo transfer or fresh embryo arms, indicating the potential underlying and inverted commas potential utility of a personalized guided approach at the first appointment. So a more recent study was by Richard Scott's group in the States, Ristenberg et al. This year. And this was a prospective study. It wasn't a randomized controlled trial, and they went into great lengths to say why they view this as good as a randomized controlled trial. So this was the first embryo transfer after a freeze-all approach. All women who had pre-implantation screening for aneuploidy and then had an HRT cycle, the first transfer, they were all offered the biopsy, and 2 out of 3 opted for it. These women had gone through a lot, understandably, therefore a lot of them said, oh yes, might as well have this as well. But a third did not opt for it. So it compared the two. Again, it's consistent in all the data that all the different groups presented this afternoon. We're finding this, it's about 60%. It's amazing how consistent the figures are. It's about 60% of women is mainly pre-receptive, and 2/3 of women were tested. But what is interesting, there was no difference in any outcome between the personalized approach versus not testing. Live birth rate across both groups was approximately 55%. Interesting. So these were not recurrent implantation patients, failure patients again. So you'd imagine perhaps if a more detailed subgroup analysis or a more focused analysis was done, maybe you would tease that out of this. There must be in some patients that potentially is of benefit, but this study did not show that. What was also a confounder in the study, they due to the outcome of another study that was published during this recruitment, showing that intramuscular progesterone seemed to reduce the risk of miscarriage, they changed their progesterone regime halfway through the study. It didn't appear that it changed the outcome of the ERA assay, which is amazing. So despite using the traditional HRT approach of oral estrogen and vaginal progesterone, then they went to intramuscular. It didn't change the ERA results. It's interesting. So, as Dr. Chang has already said, from speaking from Japan this afternoon, this is the sort of amount of data that has been compiled by Igenomix. When they did a censor of their data last October, they'd done over 125,000 samples. They found about 62% were receptive, 37% were non-receptive, and 90% of cases only one biopsy was necessary, performed in more than 90 countries. Of those that were not receptive, the majority are pre-receptive, as already been mentioned this afternoon. And what is very pleasing to see, particularly being a clinician, and understandably, if you're the poor patient going through this and paying for it, is that it is very informative. Insufficient RNA was only in 1.8% of patients, invalid in 1.76, and less than 1% was non-informative data collected. And of the local region, up to March this year, more than 20,000 samples have been done. 40% are non-receptive. Again, 90% only requiring one biopsy. There's more than 500 clinics currently using Igenomix ERA assay in the APAC region. As alluded to, the majority is pre-receptive. And what we can see now with more data coming on, and perhaps we're getting more competent at doing the biopsy, the number of times we get insufficient RNA or an invalid result is reducing. There's certainly a whole lot of data that's being amassed, and there's a lot of patients that are undergoing this. So that's really what I want to focus on, is how is the clinical utility in the clinical setting. So this is what I really wanted to focus on, because we've had some fantastic science this afternoon, and I'm trying to set the scene a bit now. So where does the endometrial receptivity assay have a place? So really, I feel this is it. And I'm going to discuss 6 cases now, and I know Dr. Nguyen presented one case, fascinating case just previously. They're all young. They're all under 35 years of age, which for an Australian population is unusual. Slim, you may say that's also unusual, but not necessarily. But unfortunately, we do have increasing obesity. They had no concurrent medical conditions. There was no concurrent gynae disorder. We've screened for fibroids, significant endometriosis by proper, really detailed tertiary level ultrasound. There's certainly no hydrosalpinges, clinical significant uterine abnormalities and submucosal fibroids. There was no concerns with embryo development. So these are patients who look at them and think, my goodness, how on earth can we not get these patients pregnant? So these are the conundrums. These are the infuriating patients for us, but distressing for the patients and distressing for us. We want to help our patients. That's why we went into this field. And so the situation is where we appear to be of no help, and we effectively feel incompetent in helping these patients. So there's a major red flag here, and I'm putting my alert out. This is a major alert. This is observational data. This is observational data with a very low N number. You could say this is pure chance. This is anecdotal data. I love scientific data. I love evidence-based practice. This is anecdotal medicine. And also, some people could throw this at me. This is surely just an endometrial scratch effect. We'd have difficulty to counter that, although there are studies which suggest that endometrial scratch has no benefit. So there's some major riders, but you're actually speaking to me now at a time when I've just had a week, which has just been from a sort of pregnancy scan result. It's been absolutely spectacular. So these patients I've had have had a fantastic, some have had a fantastic result this week. So as I'm speaking, I'm touching a lot of wood. It's been great. So the first one, severe male factor. She'd had 8 embryo transfers as another clinic, including 2 that said, let's presume it must be the male factor that's causing it. So let's use some donor sperm. So she came to see me. I felt that, so young and fit and healthy, I can't see that is the reason. Perhaps it's the endometrial receptivity. I did an endometrial receptivity assay. I didn't do any embryo testing. She conceived next cycle after we adjusted the the time of replacement. Healthy ongoing pregnancy, young fit healthy patient with that dreadful story. Next one, poor woman had previously had a previous ectopic pregnancy. Then she'd been assessed by a gynecologist and the other tube was damaged, so she'd ultimately ended up having a bilateral salpingectomy. Consequently, she needed IVF, and at another clinic she'd had 3 IVF cycles, each with a single embryo transfer. She was only getting 1 blastocyst at another clinic, so she wasn't getting any embryos for frozen transfer. So then she came to see me, and I didn't plan to do any embryo testing, as perhaps I would have done, because I didn't feel from a previous report that she would really get any excess embryos. So I just went to a fresh transfer, and we got 3 fresh cycle, and I actually had 3 frozen transfers, but which we replaced with 2 of them were biochemical pregnancies. And again, it's interesting to hear this afternoon about the slightly early pre-receptive endometrium might set the scene for a biochemical failure of pregnancy. So I felt with this the last 2 embryos that we should do an endometrial receptivity, and it again showed it was pre-receptive by 24 hours. She had a further biochemical pregnancy, perhaps it was aneuploid, and then a next term pregnancy. Again, you could say this is anecdotal medicine, but it's providing the patient information. There's nothing more infuriating, as I'm sure you feel when you're talking to your patients, that you just seem like you're doing the same thing over and over again, and the patients are saying, can you not do some clever test to try to help me understand what's going on? Then another patient, she had failed ovulation induction. She's young. In our hands, we're very proud of our ovulation induction program. We get 50% of our patients are pregnant within the first 3 goes, but if they're not conceived, then we proceed to IVF. She'd had subsequently 2 frozen embryo transfers after that IVF cycle, not pregnant. So I thought, well, we must go through IVF and test the embryos. We biopsied 3 and 2 of them are normal. So that tells me it's not aneuploidy the problem. Obviously we transferred those, but I suspect if they're not getting pregnant when with transfer of normal embryos, it must be the endometrium. Consequently, after those embryos run out, I did fresh IVF, but we did, and prior to that, an endometrial receptivity assay. Again, pre-receptive for 24 hours. We, on the second transfer after adjusting, conceived successful ongoing pregnancy. Another male factor pregnancy, you can see consistent theme here. So these where the female is as fit and healthy as you can imagine, and they're not getting pregnant. So but look at this. In another clinic, she conceived with her first fresh embryo transfer. Obviously, she thinks that her embryos are fantastic, and so did the clinician in the laboratory, understandably. Successful pregnancy, healthy term baby, and then came back, and how frustrating. 5 unsuccessful transfers with sibling blastocysts. So perhaps something had happened in that pregnancy, as we heard about earlier on. Potentially a live birth can maybe change the receptivity. We've heard about that this afternoon. So, understanding with the clinician at the other clinic, thought, let's do IVF and test the embryos. Biopsied 10 embryos, so she obviously had a great response. Only 2 were normal. Didn't conceive, came to me. I felt obviously we needed to test the embryos. I thought, and that result that she must have aneuploidy is the problem. But we biopsied them, and actually only 3 were abnormal. So I thought perhaps it isn't the embryo that's the problem. So an endometrial receptivity assay, it was pre-receptive. She conceived again after a second go. Another one, male factor. See the theme here. It doesn't appear to be the female problem. IVF cycles, 3 transfers, tested the embryo, and 2 were normal. So it's perhaps not the embryo that's the problem, perhaps it's the endometrium. So ERA assay, again pre-receptive for 24 hours, conceived a healthy ongoing pregnancy. So we're just getting tricked that it's male factor, therefore the woman's fine, and we just miss the fact that actually it could be that also there is an endometrial receptivity problem, because she seems as fit and healthy as you can get. And then, so this I've said today is actually this when I was just doing preparing my slides on Friday. Another fantastic story. Look at this. She'd had 8 transfers at a previous clinic. She underwent pre-implantation genetic testing with aneuploidy. I did a because obviously there's 8 transfers and she was young, I thought, well, we've got to do everything. I did an endometrial receptivity assay, again 24 hours pre-receptive. With her next transfer, she conceived. So absolutely marvelous results. So so yes, so you can see the pattern here. It just seems that it's where we really think that it can't be a female problem. They seem incredibly healthy. And that is perhaps where its places. So it's certainly not on women over 40, as the main issue is going to be aneuploidy. So so basically, I got I kindly asked my fellow Dr. Sebastian Levisic to have a look at my patients last year who underwent endometrial receptivity assay last year, and looked at 17 patients last year who underwent a median of 4 embryo transfers, interquartile range of 4 to 6. Who prior to the endometrial receptivity assay testing, and a median of 2 transfers subsequently. So I had a total of 79 transfers before the biopsy and 27 post. So prior to the ERA testing, 9 out of those 17 patients, about 53%, had at least a clinical pregnancy following an embryo transfer, and 2 had had a live birth. But following the ERA assay, 65% had a clinical pregnancy, 6 of which was a live birth, and a further 3 are pregnant with ongoing pregnancy. So the 17 patients tested, 35% had a receptive, and again, the same sort of story, 65% had a pre-receptive endometrium. So you can see that when all the studies that seem to be looking at patients who seem to have an implantation problem, it seems to be consistent about 60%. Perhaps it's more like 40% in first up patients, but those that seem to have an issue, it seems to be about 60% have an abnormal receptivity. So I'd like to finish my talk there with some time for questioning. So I feel the place for the endometrial receptivity assay is your young, healthy patient that, like Dr. Nguyen says, you've explored all potential causes, including the male, and looking for a sperm DNA integrity. You've thoroughly looked for any concurrent medical conditions. You've looked for any concurrent gynecological conditions. The woman's been thoroughly assessed, and ideally, you strongly suspect that that aneuploidy is not the problem. So she'll have undergone PGTA, and you know that the vast majority of her embryos are normal. That is the place for the test, because the test, as we all know, is expensive and it's invasive. And we want to make sure that we do it at the right time and for the right patient. So thank you very much for your time.
Thank you very much for the talk, Dr. Hart, for keeping the energy up, even though you are the last speaker.
No worries, Vivian.
And due to time, we have a few questions here, but we selected only one of them to ask and make it brief. So here's the question. One of the studies you mentioned looked at different progesterone regimes and ERA. So in your experience, even though the ERA test is receptive, are there any progesterone regimes which can be insufficient to sustain a successful implantation?
It's fantastic, and I'm glad you raised that, Vivian, because we're all different. We are all different. So there is some studies suggesting the miscarriage is less with intramuscular progesterone, but that's a really invasive approach to give our patients. So typically we give vaginal progesterone, as you know, with an HRT cycle, which the ERA assay really should be done using. So the reason for that is that you can standardize your time. If the patient takes it 6 a.m. and 6 p.m., for instance, you know exactly when to take it. So generally, it's encouraged, it's vaginal progesterone. But I think it's important to say this is a bit of a sort of a sidestep from the ERA assay, but we are all different. And so just taking a history from a patient, if a patient comes to me from another clinic and says, well, I take my progesterone, but I always bleed. I always get some premenstrual spotting. So it may be that her hormone levels, so serum progesterone is fine, but she may be not, the receptor may not be working adequately. So I think before we jump on the putting patients through an endometrial receptivity assay, just take a good history from the patient. If the patient gets premenstrual spotting, they're probably not getting adequate progesterone. So maybe they need vaginal and oral, and sometimes even vaginal and intramuscular progesterone. So I think the short answer to your question is it's vaginal progesterone 3 times a day, the HRT regime, which the Igenomix encourage for the ERA assay. But we're not just look at the patient as an individual and try and look for any nuance in the patient, which means that they need to have their treatment individualized before you embark on the expensive and invasive, uncomfortable ERA assay, which I'm very grateful for, and it's helped many of my patients. So thanks very much, Vivian.
All right, thank you, doctor. Just from China, okay, we will ask one last question from our colleagues in China. So it's the final one. Does it need luteal support for ERA detection after the GnRHA down regulation?
I'm not quite sure I understand the question, but if you're saying you're doing an HRT cycle with long down regulation, absolutely, absolutely. The whole point of that is to cause down regulation, so there will be no ovulation. And 1 in 10 cycles, despite HRT, the woman actually will ovulate with an HRT cycle. There's some data from the 90s showing that. So if you want to be completely purist about it, then perhaps you should do a long down regulation. But it's not a pleasant experience. The woman has some sort of menopausal hot flashes before she starts, so it's not generally that we do that. But as a previous speaker, I think it was Dr. Chang, alluded to, you really should do your serum progesterone level a day before your ERA assay, just to make sure there's a pretty much unrecordable serum progesterone, because obviously that would suggest that the woman hasn't ovulated. So I would encourage that, perhaps not the long down regulation, just measure the serum progesterone, then the next day as is planned, do the ERA assay. So a fantastic question. Thank you.
All right. Thank you, Dr. Hart, and thanks for the audience. Thanks to the audience for the questions. Thank you for your participation. Now we will move on to the closure. Thank you.